Hi, I'm Sreedhari, Endoscopy Research Fellow from Portsmouth, England. I and my co-authors would like to thank the Journal of Gastrointestinal Endoscopy for their invitation for us to speak about our meta-analysis looking at the role of endoscopic technological innovations for neoplasia detection in organised colorectal cancer screening programs in cohorts with a positive fecal occult blood or stool fit test. Organised colorectal cancer screening programs based on positive FOB or FIT tests have consistently shown to reduce the incidence and mortality of colorectal cancer due to increased detection and removal of neoplasia. They have therefore been widely implemented, but carry a significant economic burden to healthcare services. Therefore, any new technology that's considered for implementation into colorectal cancer screening programs needs to be backed up by unequivocal levels of evidence to encourage their incorporation. Two broad types of technologies have previously been studied looking at neoplasia detection in colonoscopy. One category includes advanced imaging, such as narrowband imaging, blue laser imaging, and diffuse colonoscopy. Second category includes mechanical devices such as distal attachments, for example, the endocuff, the endoring, and the transparent cap, and GI colonoscopy. Recent studies have largely focused on the role of these technologies in unselected populations. The aim of our meta-analysis was therefore to look at the role of technology-assisted colonoscopy, specifically in cohorts with a positive fecal occult blood or stool fit test. Our inclusion criteria included fully published parallel design randomized controlled trials and trials where subgroup analysis on positive FOB or fit cohorts were included. Studies were excluded if they were of a tandem design, if they were retrospective or non-controlled, if they were an abstract format, or they did not specify whether the cohort had a positive FOB or fit test. After our systematic search was performed, we retrieved 8 high-quality parallel design trials, of which 3 looked at advanced imaging and 5 looked at mechanical devices. A total of 3,645 patients were analysed, and approximately half were allocated to standard colonoscopy and half had received colonoscopy technology. For our primary outcome measure of adenoma detection rate, our analysis showed no significant difference in the pooled adenoma detection rate between standard colonoscopy and the intervention limb, with a moderate degree of heterogeneity. There was also no significant difference in our secondary outcome measures of mean adenomas per procedure, advanced adenomas, proximal adenoma detection rate, and the cancer detection rate amongst standard colonoscopy compared to the intervention limb. Pooled cecal intubation rates were also not significantly different between standard colonoscopy or the intervention limb. There was no significant publication bias found. The role of technology-assisted colonoscopy is uncertain irrespective of the setting. A recent network meta-analysis by Fadjura et al. Showed that the contribution of technology-assisted colonoscopy was more relevant in low adenoma detectors, where there was a marginal increase in the adenoma detection rate. In organised colorectal cancer screening programs, endoscopists' participation is subordinate to a high baseline adenoma detection rate. And in our meta-analysis, the mean baseline adenoma detection rate in the standard colonoscopy limb was 56%, so very high. This could explain why the efficacy of technology-assisted colonoscopy was not shown. A limitation of our study is that the number of studies on individual modalities were low. So some technologies had only one study for example, the GI study, the FEW study and the EndoRing. However, when the technologies were grouped into advanced imaging or mechanical devices, there was still no significant benefit shown. In conclusion, our meta-analysis has not shown a significant difference in the pooled adenoma detection rate amongst standard colonoscopy to technology-assisted colonoscopy in a setting of endoscopists performing high-level colonoscopy with a high baseline adenoma detection rate in cohorts with a positive fecal occult blood or FIT test, and therefore recommendations for their implementation cannot be currently made. I hope you enjoy our paper.